So, hi everyone. Welcome to Taking Pride in Medicine, a session collaboration between Gender and Sexuality and the Wellness and Student Life Action Committees. My name is Brianna Gardner, and I am the LGBTQ plus coordinator, program coordinator, and I'll be your moderator today. You will be hearing a presentation from Dr. Perry Tsai, MD, PhD, who is a graduate of Harvard College as well as the University of North Carolina at Chapel Hill School of Medicine. He also served as the 2018 and 2019 AMSA president and is still very active in AMSA today. He is currently doing his residency at the University of Illinois, Chicago in psychiatry. So please let's give a warm welcome to Dr. Tsai.
Hey, thanks for having me. I really appreciate it. Just to clarify my last name, I typically prefer it Tsai. And by text, you wouldn't have necessarily known that. It's okay. It's good to see a lot of friendly faces and friendly names that I know. And yeah, I've had a very long history with AMSA. Really enjoyed my time with AMSA and learned a lot from AMSA in both leadership skills and organizational work and advocacy, as well as particular topics that I was interested in, including sexual health, sexuality, LGBTQ health, and those topics and considerations in medicine. And I'm really honored to be able to come join y'all and talk about these issues because they're very important issues, and I think that the awareness of them is increasing among healthcare professionals and increasing in medical education, but there's still a lot of room for growth in terms of the things that we know and the things that we are teaching and the ways that we are caring for LGBTQ people in our country. And a lot of that is borne out in disparities in access, disparities in various healthcare outcomes. And so I'm really pleased that this is something that we're discussing, particularly this month during Pride Month. I don't have any formal slides, and I do want to make the disclaimer that I'm not necessarily a recognized expert in any of these issues. I'm still a resident in training, but these are issues that are important to me and that I've had the opportunity to learn about and teach about in my time with AMSA and also at UNC Chapel Hill. And so I'm happy to sort of discuss these issues and talk about them. And I'm also happy for this session to itself be a little bit of a conversation, because I'd love to hear what other people have experienced and how they're addressing these issues in their own education, at their own institutions. Because I think over the past decade, it's been a very dynamic and heterogeneous, but generally things are moving forward. It's just, every institution is doing it in a slightly different way. So I think that y'all maybe have collected some questions that I can sort of answer, and we can discuss and sort of have a more informal conversation around the topic, right?
So one of the questions we have is how do our current definition of professionalism in medicine negatively affect LGBTQ plus individuals, particularly those who are not white, wealthy, or cisgender?
Mm-hmm. Wow, we're cutting deep real fast there. Speaking of, well, I forgot to introduce myself more formally in terms of my pronouns are he, him. I do identify as a cis man who's also gay, for what that's worth in this conversation. So the question is about sort of professionalism and how that affects our experience in medicine. And I think that the way this comes up And the way this question is posed is quite intersectional in the sense that regarding economic status, regarding race, regarding sexuality or sexual orientation. And so the stories that I hear, the anecdotes that I hear are regarding particularly ways people dress, ways people express themselves through either makeup or hair or clothing. And I think certain aspects of the ways that we express our sexual identity too, because they don't fit into these historically normative white, cis, straight molds, people consider them either radical or unprofessional. And I think that you'll see this in medicine because medicine itself is a bit of a conservative specialty if we think about it in broad strokes. And then there are certain pockets of medicine too, which are more conservative than others. Like you typically hear about like the surgical specialties being a little bit more conservative, while other specialties like psychiatry, for example, might be a little bit more progressive or liberal. And a lot of that is actually borne out in surveys regarding people's political affiliations across specialties. So I think that the experiences that I hear about are people being told that they're being unprofessional, or like even to the point of dress codes being defined in such a way that are excluding of other non-white or non-cis type expressions. I think that like being a gay person myself, the ways that comes out might be in discussions about romance, relationships, or sex. And in specific situations, some people think that's inappropriate. And it's sort of the same vein of people like seeing two same-sex or same-gender people expressing affection in like a movie or TV or something, and like people consider that sort of taboo. And so there's often this like think of the children type reaction. And obviously, like when we're trying to consider heteronormativity and thinking about heteronormativity, this just doesn't make any sense. Like that heteronormativity, there's no reason when we think about LGBTQ equity and rights and keeping these people not as like alien or not as second class, then these types of expressions should not be considered taboo or should not be considered inappropriate. But they are, because a lot of people are brought up a certain way or hold certain beliefs, just hold certain values. And so I feel like when those things are looked down upon, then those things should be, those types of policies or those types of things should be called out, and we should stand in solidarity with other types of expression that are looked down upon, that are associated with race or associated with class. I think in medicine, we're always trying to strive for diversity, and the part of that aspect is being welcoming of diverse types of people, that includes their whole person, that includes their expression. And it's being able to be in a safe space for all these different types of people creates a more welcoming and diverse environment for people to enter medicine and enter that healthcare professional workforce. Wow, I think I feel like I just rambled for a very long time, but I hope I sort of addressed the question I was asked.
You did. Thank you so much. Another question that we have submitted is, what are some helpful tips for engaging in uncomfortable clinical moments?
Oh, yeah. Yeah, so I remember hearing a lot about this when I would teach about sexual health to other medical students. And there was often that question, just like, oh my God, how do I ask about sex, or how do I ask about gender? And the easiest answer I can give is just practice, which is like sort of a throwaway answer. Like that's the non-specific. Like I can tell anybody to practice anything. But that's actually I think part of it. Like for example, like during one of my sexual health lectures, one of the things I would do with the students was I would say I would tell them to repeat after me, and I would say um, I am sexy, and then I would make them say I am sexy, and then I would say my friends are sexy, and I would ask them to repeat that. Um, then I would say my parents are sexy, and then I would tell them to also say my grandparents are sexy. So this is very specific to sexual health and sort of addresses the point and forces the person or the student to acknowledge that everyone has some sort of sexuality in their life experience. Um, and we can even include asexuality in there too. And that's a type of sexuality on that spectrum of sexuality. And the point of that exercise is just for you to get used to the idea. We often think about sex and sexuality as this very private matter, which, for obvious reasons, there is an element of privacy that exists and should exist when we talk about sexuality. But it's also something that we have to acknowledge, particularly as healthcare professionals, because it is a part of our patients' identities. And in some cases, it's a direct aspect of their healthcare that we have to think about actively. Um, and so when we're building relationships with our patients, we have to acknowledge that and grow more comfortable with that idea that everyone has some sort of sexuality. And so I think broaching these topics, you just have to become comfortable with it. And part of that requires a little bit of self-awareness and a little bit of emotional awareness in yourself. Like, where do you sit along the line of comfort? Because some people like were brought up by very queer positive parents or in like very queer positive environments, and they're like totally cool. But some people may not have had that same experience, and so they might require a little bit of comfort building in themselves. And so you just have to be self-aware about that. And then just practicing those words, practicing the questions, and also like before you enter these patient encounters, think about how you're going to ask a question and think about the wording. And this is something I do every day in my own practice in psychiatry, that I ask very sensitive questions, and so I have come up with ways that I feel most comfortable asking those questions and that make most sense to me, and get the right question across so that I can get the right information. And so I think another piece that can try to add comfort is try to normalize a lot of these questions and normalize them in different spaces too. So particularly when we're talking about SOGI data or SOGI, like sexual orientation, gender identity questions, I think a lot of practices have moved towards adding SOGI questions to their intake forms. So if we think sort of 2 or 3 decades ago, a lot of intake forms would typically include male or female, and then would include like, okay, do you have a spouse? What's the spouse's name? Or like wife or husband. And so stuck in these very sort of gender binary, heteronormative type systems. And so a lot of intake forms are now moving, as well as EMRs too, are moving towards more gender inclusive and sexuality inclusive type questions. So for example, including transgender identities in your gender identity, and moving language towards a certain way. So like I was actually one of my colleagues who is in a gender sexuality clinic here, like for example, when we're talking about transgender persons, as far as maybe 10 years ago, um, we would often use the acronym like MTF or FTM. So like male to female, female to male when we're talking about transgender identity. And then my colleague actually educated me that some of that language is evolving. And so, for example, someone who's transgender male who was assigned female at birth, it's actually some of the language is evolving to include that. Like, so transgender male, AFAB, like assigned female at birth, which sort of takes away some of this directionality about transgender identity, and then also sort of makes the language such that the person wasn't female at birth, but they were assigned female based off of their the way that their anatomy looked at birth. So it sort of acknowledges this like gender identity that's a little bit more permanent. Sorry, I took a tangential sideway there. We're also starting to ask sexual orientation too on intake forms or in EMRs, because that can be important data not only for a patient themselves, but also I think in starting to collect that data on like a system-wide basis is also very important, because since we haven't had that data as frequently previously, we don't know as much about like the population-wide type health disparities that exist in LGBTQ populations. Sorry, I realize I'm taking tangents, and I'm going to try to come back to the question about the comfort of asking these. So intake forms, practicing, I think always prefacing sensitive questions with like very normalizing prefaces, like I ask all my patients these questions, or these are just more questions I'm asking to like confirm some of the demographic information or just to get to know you better. And you don't have to necessarily assume that, or you don't have to necessarily assume that they might have an issue, or assume that they might feel stigmatized, or assume that there's a problem. But you can always ask sort of after whatever they say, whether they say they're straight or whether they say they're gay or whether they say they're cisgender or transgender. You can always ask, so do you have any questions or concerns about your gender identity or sexual identity? And I think those are always like reasonable questions in the right setting. So in sort of an evaluation or intake or first visit type setting when you're starting to get to know your patient. Obviously, when you're in a more complaint-focused interview, things are not going to, you might not have time for certain parts of these parts of the interview, but wherever you can fit it in. Anything else? No, I think that was pretty much all I had.
Thank you. So the next question we have is, Pride Month gives us an opportunity to share stories of struggle and strength. Is there a particular example of this experience that you feel comfortable sharing with us?
Struggle and strength. I don't know. I'm going to be honest that I feel like I've led a very privileged life. And I haven't had as much like, I mean, when we're talking about like my queer identity, I feel like I've always been in pretty supportive environments. And I mean, we could go into my own coming out story with my own family, but that might be a little too personal for this setting. I don't know if anyone else on the call might have some more personal stories, but I don't think I have anything constructive to add here.
So another one is, so LGBTQ plus health is often reduced to sexual and mental health topics. Could you speak to some of the additional LGBTQ health issues that do not belong to these two domains?
Yeah, so this is something that always comes up, and like very classically, when we think about gay people, we think about HIV. Like that's sort of the association that's drilled into your head. Um, or we think about mental health issues, or we think about substance use issues, and those are actually all big issues. Like they're very I don't want to use the word comorbid, but I'll use the word prevalence in these populations. And so the HIV issue is obviously very high prevalence in men who have sex with men, as well as transgender populations. And so that's like it's just a thing. It's just a thing to know. But again, like with any, as you sort of go through medical school, you start to, I mean, you learn these almost memory tricks, right? So you learn these associations because there are associations, and then as you go through your training, you start to like gain more wisdom about these associations and like keep it in the back of your head, but based off of a person's whole story, your differential diagnosis is always being like managed with other considerations. So like, for example, like a gay man, you're going to obviously think about the association of HIV. But if you have a gay man who has been in a monogamous relationship for X number of years, isn't an IV drug user, like those are things that'll decrease their risk for HIV. And like if their presenting symptoms are not consistent with any HIV infection, then you're going to take that whole picture, and then HIV is much lower on your differential. So I think that you have to take these associations and then just like intersect them with other pieces of information, right? I think that depression, anxiety are things that will happen across the board, and maybe higher in LGBTQ populations. And a lot of that you have to sort of understand is not like being gay isn't, or being queer or being trans is not itself at a risk of mental health issues. But the mediator that's most likely happening is the population is experiencing the societally driven distress or stigmatization, which includes emotional stress, but also includes the stressors of like institutional discrimination. So like as a population, more difficulty with income or employment or housing. And so those are also things to consider. Substance use is another issue that comes up with increased tobacco use, increased illicit use, particularly in gay male populations. Like you often hear about like meth use, those are other associations. So I think I'm starting to trend into the opposite direction of what the question is intending. So like, what are things that like are not these things, right? So a lot of the things that we think about are not necessarily like specific to being queer, but are related to like healthcare access and some sort of social network likely mediated issues, and then so when we think about LGBTQ populations, a lot of the things I just described in terms of like socioeconomic stressors, or also like poor experiences with the healthcare system, then sort of downstream result in LGBTQ people not having as good access to healthcare. So like maybe not having health insurance, or maybe just being scared or not willing or not wanting or feeling like they wouldn't be welcome in a healthcare environment. And so that sort of drives decrease in healthcare utilization, decrease in like getting their meds, or possibly increased emergency department utilization. So like generally just like lower primary care utilization, and so not as effective healthcare maintenance or preventive healthcare. So that all comes from sort of a healthcare access standpoint. And then you have all of your issues that come from there. So people who don't maintain like their primary care visits or healthcare maintenance, then they're more likely to have exacerbated chronic conditions and then possibly like utilize the ER more. So a lot of those things can happen. I think some of the substance use issues are somewhat like societally induced or socially induced, in the sense that, like, for example, there's a thing that, well, there's like increased tobacco use among gay men, and I think as well as, well, I think queer populations in general. And then I mentioned sort of other increased illicit use. And like, it's not that being queer necessarily makes you more likely to use tobacco, but some of it is like being in those communities that may already have like a high prevalence of smoking. Then you're sort of inducted into these communities, and then you sort of take that on in order to try to identify with that community. Or also like just general emotional stress of being a gender or sexual minority sort of makes it more likely that you'll use something like tobacco or alcohol. And what was the other thing I was going to say? Oh, the healthcare access piece, I think, also comes out in like cancer screening, like lower cancer screening. So then poor outcomes with regards to that. Other like non-mental health, non-substance use, non-STI stuff. Oh, reproductive health, like fertility issues is something that comes up. This comes up in like Master of None just came out with a new season in Netflix, and like it's actually really interesting to watch that. There's a lot of the insurance policies that have like reproductive health or like fertility type policies, or like what they'll reimburse, are sometimes rooted in like heteronormative ideas of, you know, parenthood and like fertility. And so a lot of same-sex partners or same-gender partners can have a lot of difficulty getting the same access to fertility services or fertility treatments. So that's like another space that's, you know, very specific to like the OB or endocrine space that comes up for non heterosexual couples. What else? Yeah, I think those are some of the ones that come to the top of my mind. I'd be happy to hear if anyone else has things to add.
Thank you. Oh, do we have some more? Okay. Thank you for that information. The next question we have is, the medical field has a history of perpetrating discrimination and violence against LGBTQ plus individuals. What examples have you seen of recent collaborations between LGBTQ individuals or groups and medical professionals that have led to improvements on LGBT people wellness?
Sure. So I appreciate the preface and the question about like medical field has like been really crappy to minorities generally, and that includes racial minorities, includes Native Americans, and includes sexual minorities, gender minorities, and some of that is part of the history of psychiatry, and so I think that a lot of the space where this is changing is on the education level. So like I think a lot of medical schools, and I think AMPS has obviously been a big part of this, have really improved their education around LGBTQ identities, LGBTQ health, and I think it's sort of changing on both an organizational and individual level. So I think generally the society, like both medical and non-medical people, are becoming more aware about LGBTQ identities, and so becoming more comfortable with those issues. Um, and so I think things are becoming more welcoming overall. If we're talking about like specific organizations, like the ones that I've worked with and the ones that I've had the pleasure of talking to, and interacting with include like GLAMA, which historically was the Gay and Lesbian Medical Association, but it is now just referred to as GLAMA, and it includes various professions, interprofessional members, that I think is one of the few organizations that very specifically working on LGBTQ issues, which includes both interfacing and collaborating with legal organizations, and advocacy organizations like National Center for Transgender Equality. And they also interact with some of the other medical associations like the AMA, which has slowly been modifying its own policies, and its own principles, that are becoming a little more gender affirming, and or gender affirming and sexuality affirming. So I think that a lot of it comes from advocacy against policies and legislation that are discriminatory against queer trans people. Like for example, the FDA blood ban against gay men. That's one of the things that has the needle has been moving slowly. I think they recently decreased the number. It used to be that like if you're a gay man who's basically had sex with anyone since the 80s, then you can't give blood, which is just like bonkers, right? I think they decreased it to like 12 months. If you haven't had sex, if you've had sex in the past 12 months, then you can't give blood. But they might have decreased it, I think, to like 3 months or something. Or there's also advocacy around like healthcare and insurance companies sort of including or excluding gender affirming care. Those are other spaces where there's advocacy. There's advocacy around like intersex issues. Intersex meaning people who are born with various aspects of their like biological gender that are not like all one direction, and so they may have some ambiguous genitalia, or they might have aspects of their hormones that are not all in one direction of like if we're talking about the male-female spectrum. And there's this like really terrible history about surgeries of neonates or infants to try to like correct these genitalia. So there's advocacy around that to try to stop these surgeries and allow these children to grow up and identify with whatever gender they have identified with and making their own decisions about their bodies. What else? There's the Pride study. I know some of the investigators on that. That's been starting basically like the first like longitudinal health study on a large LGBTQ population. Yeah, there's a lot of spaces where advocacy is happening, sort of on different levels from federal to state legislation to medical institutions. And then, at the most sort of minute or a concrete level of like clinics changing, the way they practice, or their own policies, or like doing more sort of staff trainings on LGBTQ sensitivity. I think a lot of those things that are spaces where things are changing, and we're trying to just be more welcoming, and trying to just make things more equal and equitable for queer populations.
Thank you for that. So I'm gonna put out the thing to recognize Hannah to speak.
Uh-oh.
Oh, there it is. Hi. Good to see you, Perry. I just wanted to also give a shout out to a newcomer in this space, which is the Med Student Pride Alliance. We were fortunate enough to have one of their student leaders come and talk to us at convention this year, but they actually have some pretty cool stuff going on this month as well. They actually wrapped up a documentary screening about getting like LGBTQ identities removed from the DSM and stuff like that. They are doing some cool stuff this month, and I'll share a link in a moment. So they are a great group of folks who are also medical students who are doing some advocacy work in this space as well.
Nice. Yeah. They're coming. Are the leaders still at Stanford, or are they?
I think they have expanded.
Okay.
They grew pretty rapidly in the last year or so.
Okay, nice.
We also had a question that Tyra wanted to ask. So Tyra, you can unmute yourself and ask your question.
Hey guys, there we go. Is it working? Is it working? There we go. Hi, how are you guys?
Good.
Good. So, the reason I wanted to ask this because I just want to give a bit of background to why I'm asking the question. But I wanted to know, I come from South Africa. So this is now a country that is not very big into mental health awareness. It's a country that is not very big into LGBTQ plus education and information on it. And I've just recently joined with AMSA, and so far I've made it to be my chapter president. And I wanted to come today because I am a straight woman who has never really dealt with the awareness of LGBTQ. And I wanted to know if you had any pointers for me going forward in medicine as a leader, as someone who is straight, to make myself an ally and an asset to colleagues and patients who are LGBTQ. Is there something I should be looking out for, something I should try and consciously be aware of?
Mm-hmm. All right, thanks, Tara. Congratulations on being chapter president, and thanks for coming. Yeah, this is such a big issue because, and I think it's not only for queer advocacy, but also for racial advocacy and racial justice too. This tension for people who are in the majority, or people who have those more identities with privilege, like how do you be helpful, right? And how do you do it in a way that is still empowering of the population that you're advocating for? So I think that throughout, like when you're in that stage of medical training and medical education, there's sort of what you can do on a very local level, like within your own institution. And so One of the things that I remember working on and sort of passing along at UNC Chapel Hill, which is where I did medical school, was just being aware of how medical education was being brought up and how identifying pockets of heteronormativity or cisnormativity. Like for example, like the gay man HIV thing, right? Like that's sort of your classic thing. And so like it's gonna come up. Like you're gonna get a lecture about it and it's gonna come up and people are gonna talk about it. And just so like being aware of how that's being presented, and sort of trying to challenge that when you can. The other space is just like, is there any LGBTQ curriculum in your medical school's education or curriculum? And like, I think as maybe in some of the studies from about a decade ago, there wasn't a lot, like in at least in the North American medical schools, like there wasn't a ton. And I think that's changed a lot in the past decade. So just being aware of like what kind of education you're getting, how it's being taught, and what is being taught, and how much is being taught. And then where you can make interventions. And so if you find something or something that's problematic, like can you intervene on that and sort of suggest an alternative way to that educator or lecturer or professor or whatever? Can you get involved in the education committees at your school and try to make interventions? For example, like trying to add an hour or two of LGBTQ education. And the way this starts off in a lot of medical schools is like, it's really hard to change medical school curricula, like really hard, because it requires buy-in from a lot of levels. It requires you to like work within these very tight curricular schedules that are getting even tighter now that a lot of preclinical curricula is being shortened to 18 months. This might be completely different in South Africa, because like I know that outside of the United States, medical school, it looks very different in terms of timeline. But because of that, a lot of ways that LGBTQ education has started off has been through sort of these more supplemental events like lunch learns or lunch talks or little screenings of movies or whatever. That are more extracurricular, and then as you do them, you sort of get some evidence or learn that people are interested in these topics, and then it gives you a little bit of platform to be like, hey, we want to learn about these things, we should put in the curriculum. Another like intervention that we did was like, you always have you always get like problem-based learning or case conference type things where like you get a patient presentation, you have to talk through the differential or the workup or the management. And a really easy space to sort of challenge heteronormativity is in those specific patient descriptions, where you can start to include people who might be trans or who might be queer, might be gay, or might have a same gender partner, and sort of normalize that, because it could be just a case about acute kidney injury that has nothing to do with their sexuality or with their gender identity, or it might. So being able to have people put those realities into their head as things that they may or may not encounter. You can also consider even trying to get standardized patients who might have these identities as part of their narrative. That's another space where you can just start to like, instead of ignoring these populations, start to incorporate these populations, these identities into education. So yeah, I think that at your level, that's a lot of great places to start in terms of trying to change things at your own school.
Thank you, I appreciate it.
Yeah, of course. Thanks for the question.
So, as we all have seen, the COVID-19 pandemic has highlighted the difficulties of navigating mental health challenges perpetrated by unacceptable home environments. What resources or avenues can you give us for LGBTQ individuals to pursue and to protect their health and wellness?
Oh my gosh. I don't know how to answer this question. I mean, a lot of the issues that have come up from COVID have been around the problems of like housing and employment and income and the difficulties around that. And they've hit all the minorities harder. So like particularly like Black minorities, and I don't know the data around like gender sexual minorities, but I can only imagine that it's hit them harder, particularly when we talk about access to healthcare and other discriminatory issues. I don't know. I don't know if there's like specific resources regarding COVID. Let's see. I'm literally gonna Google right now. I'm curious now. This is what happens when we do Zoom meeting, because I'm on a computer and I can just like look things up. It looks like HRC has a page on an issue brief. Okay, it doesn't tell me much about like specific resources.
Kind of in that vein, what resources do you give to patients who are concerned about safety at home? Because I think maybe where this question was going was like for that period where we were all at home more often than usual, or maybe a little bit stuck. There were definitely some concerns from some folks who don't feel safe in their homes. So what advice would you give to medical students who are trying to advise somebody who doesn't feel safe?
Okay, yeah. So domestic violence. I should have mentioned this before regarding like LGBTQ populations. But yeah, so domestic violence is also an issue across LGBTQ relationships, and it's a space, particularly when we think about like gay male relationships. It's something that you may not necessarily think of, because like when we think about DV, domestic violence, we often think about the high prevalence in females as victims or survivors. And so like gay male spaces are where that men can also experience that as well, emotional, physical, financial abuse. Yeah, so that's when we're talking about, okay, let me take one disclaimer that like some of that depends on the laws within your state. And you have probably encountered some sort of training around this about like being a mandated reporter, right? So for example, in Illinois, and it might be true of other states, like if someone is a minor or if someone is, and there's like some reasonable concern for their safety or of some sort of abuse, then you're a mandated reporter. That's just like how it works. And you have to either contact like departments, whatever governmental department, like in Illinois, it's DCFS, Department of Child and Family Services. So that's like just a thing. That's just like a concrete rule. When we're considering adults who are not elderly, a lot of that will depend on what the patient wants to do themselves. And so there's sort of your general rules about like not blaming the patient, and also not telling the patient like what to do or what is right to do, because there's there's a lot of factors involved in what they decide to do or not to do. So the only thing you can do really is trying to provide options and trying to provide information, and doing it in a way that's not going to put them at harm's way. So it can be a very tricky situation, and you can also you can always try to provide some sort of domestic violence there exist shelters depending on where you are, that might be an option. Trying to help them sort of develop some sort of safety plan can also be an option. But it's very challenging, and it's very difficult for us to intervene at a healthcare professional level, because there's just like not a lot we can do. Like I can't prescribe a medication or anything like that. And I think that there are sort of, I think one of the spaces where we can try to be helpful is just recognizing these issues and sort of being able to identify when it happens. Because if you're not thinking about it, or if you're not aware of it, or aware of the potential red flags, then it could be easy to miss, and you could be missing an opportunity for intervention. So I think a lot of it comes with like recognition. And so, you know, asking the questions and asking, you know, in a private setting, like the patient about whether or not they feel safe at home. What happens when they and their partner have fights or have arguments? And sort of trying to suss that out and leaving a space open for someone to identify those types of problems. I think that's really probably more important for people to learn and people to understand and be aware of. More so even than like being the person to fix anything. And yeah, it's a tough space. And thank you, Ebony, for putting the hotline in there. You know, I think there's some more general type resources that you can give out. But I think, I don't mean to deflect the question, but I think honestly, trying to create a space that allows someone to identify those issues is probably more key and more critical.
Thank you for that answer, Dr. Tsai. We are starting to run out of time. We really want to thank you for coming to talk to us and answer all our questions, and being open to all our questions.
Yeah, no, I love teaching, and I love teaching medical students, and I love talking about these issues. So I really thank you for the opportunity to come join y'all today.
Thank you so much again. So I'm just going to give some last minute information of how ways people can get involved. We have, AMSA has the Sexual Health Leadership course, the Trans Health Scholars Program, and we also have an LGBTQ pre-medical and medical student Facebook group that we will put a link into the chat. And we're also, the University of Maryland Medical Campus will be having an event tomorrow on June 17th at 12 p.m., where there will be continue the conversation of sexual health within the LGBT plus community. The registration link can also be found in the chat for anyone who may be interested in attending. And again, we want to thank you, Dr. Tsai, and we truly enjoyed this, and thank you so much.
Thank you. Thank y'all. Have a good rest of your day.